From the Regenstrief Institute, this is The Problem. The Problem is an anthological podcast dedicated to fighting the hydras of healthcare, those complicated, big, hairy issues that impact healthcare on the societal level. Every season, you'll hear about a different, big, massive problem, and each episode within that season will feature a different discipline or industry's take on that problem, how it's being addressed, how it's being talked about, and the trials and triumphs of those involved, clinically and personally. This season is all about opioids. Over this series of episodes, The Problem will talk about how we, local communities, Indiana, and the United States, got into this crisis, how people suffering from addiction are treated, and how the needle can be moved on addiction. This is a podcast for anyone who might be interested in how these problems have developed and how they're approached. You don't need a PhD to be affected by them, so you shouldn't need a PhD to learn more about them. Regenstrief Institute is a global leader dedicated to improving health and healthcare through innovations and research in biomedical informatics, health services, and aging. Welcome to The Problem. It's been a while since you were in the doctor's office. When you were there last time, she gave you your diagnosis and she wrote you a prescription. It seemed serious. She asked you if you had any questions, and of course you did, but in the moment, it all seemed a little much, a little overwhelming. She told you to call the office if you thought of anything else, that she was happy to help. You started the long drive from the city back to your home in the sticks, and then you got back to life. Months go by. You take the medication as best you can. Sometimes you go to groups online that talk about your diagnosis, and they seem pretty helpful for answering questions. You try and change your habits, and in a few months, you head back in for a follow-up. It's gotten worse. Your doctor tells you some other changes you should have been making. Changes the groups never even discussed. She tells you the foods you should have been avoiding, exercises you should have been doing. It's all brand new information to you. A lot of brand new information. You go home and you keep trying. Who knows what she'll say next time? From the Regenstrief Institute, this is The Problem with Phil Lofton. Millions of Americans live with limited access to medical care. It's estimated right now that nearly 1 in 6 Americans live more than 30 miles away from a hospital with emergency services. And that number is not expected to go down. That's just the tip of the iceberg, too. About a third of women who live in rural areas have to drive over half an hour for OBGYN care. Scarcity of mental health, dental, and other specialized care can even lead people in rural areas to load those responsibilities onto their family doctors, many of whom don't have adequate training to deal with those needs. And that's not even mentioning the gaps in communication that can lead to serious medical misunderstandings. After all, what if a doctor and patient can't communicate well about the seriousness of a condition? What if there's a serious roadblock in how those two parties talk about health goals or nutrition or exercise? It helps to have someone in the community, from the community, that has a similar background. Someone who can visit folks in their homes and see how they're living, day to day. That's where community health workers come in. Community health workers, who were called the new professionals when their profession was first recognized, are part of a medical tradition that goes back to the early 20th century in China. The barefoot doctors of China were individuals who received about 6 months of training. For 50 years, a total of nearly 2 million barefoot doctors served the poor and rural areas of China, providing public health services like family planning and medications, as well as Eastern medicine treatments. These weren't just city people who were dropped into the country, though. Most of them spent around half of their lives as farmers, so they were very aware of the context of the lives of the people that they treated. Other countries and other organizations saw the benefit of this model, and they gave it a shot. In Bangladesh, BRAC, formerly known as Building Resources Across Communities, trained and mobilized locals to become paramedics. In Iran, Brazil, Tanzania, and more, community health workers have been mobilized to help reduce infant mortality to astounding effect. But what's that got to do with opioids? And what's that got to do with Indiana? Meet Deb Litzelman.
I am a professor of medicine at IU School of Medicine. I'm the Associate Director for Health Services Research here at Regenstrief Institute, and I am the Director of Education for the IU Center for Global Health.
Over the past few years, she's made an impact getting community health workers out and involved in central Indiana through a series of projects.
The community health workers that have been involved in the projects that I've worked with here in Kenya and in Indiana are lay workers, so they are purposefully intended to be people who come from the communities in which they're working and serving. They've grown up in the community. They know the nuances of what it's like to live in the community. They look and talk like members of the community, so they're embraced by those that they come and knock on their door or engage in the community. Our community health workers here in the United States and Indiana on our projects are maybe high school or GED equivalent. Some of them do have a little bit more formal education, but that's not required. And in fact, it's, actually sometimes it's makes them less approachable. So we have carefully selected them for their communication skills, their empathy skills, their ability to want to serve and be out there and about. But those are the most important aspects of our community health workers. They are not social workers. They are not nurses. They are not public health workers in any way. So they're trained as health coaches. So that's another name we have for them, and they really are coaches. They're there to be supportive. They are trained, so they have information on our 5 pillars, on smoking cessation, on food insecurity, obesity, on substance abuse, mental health disorders, anxiety, depression, on safe sleep practices for infants, and on breastfeeding. So those are our 5 pillars that they focus on, and they have resources and information on all of those. They also are connected with a lot of the community resources so that they can get mothers and grandmas and fathers pack and plays for safe sleep and sleep sacks, and they can help them get signed up for WIC and tell them what they need to take to the office to get that done, et cetera, et cetera. So they are, they're quite competent lay workers who are really connected. They're known by the community. They're accepted by the community members. There's no barrier between them and the healthcare system, or them and somebody with a white coat, or somebody who they perceive as being authority, who might judge them, who might, just not be available for them when they most need them. And they're out in the community, so they are out and about doing home visits. They'll meet the folks anywhere they want to meet, laundromat, etc. Our first responders are connecting them. So these are folks who never make it to the door of our clinics or our hospitals. So they're very key to accessing those who are most in need, who don't ever show up on our doorstep or show up too late.
A while back, Dr. Litzelman started with We Care. We Care recruited new mothers, then partnered them with coaches who would help them form good habits. What's more, participants regularly received text message updates about local resources like free diapers, free food, and more. It was very effective, but they started to notice a pattern.
When we looked at the 1,500 people we were following for We Care and We Care Plus, 15% were self-reporting concerns about or reporting use of illicit substance, medications that were not prescribed to them. Opioids were among the list, but there was also methamphetamines, a lot of marijuana, and this is separate from smoking. Smoking is another huge addiction concern that we have for our moms and women. So that's, in brief, why we decided that this was a perfect opportunity to overlay the concerns around opioid addiction and substance use disorder on top of We Care Plus.
Care Plus is a new program. Recovery coaches approach women at local hospitals who have recently given birth to a baby suffering from neonatal abstinence syndrome.
NAS is neonatal abstinence syndrome. So that is the syndrome that a baby shows at the time of delivery if the mother has had a substance use disorder and has been actively using during pregnancy. It can be that that woman was actively using illicit substances, or might have even been on Suboxone or methadone. And the baby, because it's in their system, will have withdrawal symptoms that could be minimum or severe enough to put that baby in the intensive care unit for, sometimes several weeks, if not more. And so those women who deliver often need a lot of support, a lot of care, a lot of training on how to attach with their child, who can be quite irritable and very hard to calm just because of the withdrawal. The mothers often feel like they're guilty and are ashamed, and then also feeling like they don't have the skill sets to take care of that baby. So everything we can do to help them gain those skill sets and keep the mother-baby together, as long as it's a safe environment for the child.
CarePlus works with these mothers. They recruit them into the study, and then they start to help them.
Well, we measure intake, the risky behaviors, and then the follow-up is documented by our community health workers. So if somebody screens positive for smoking, for example, the community health worker will follow up. They will use motivational interviewing methods that they're trained in to assess the person's interest and readiness for change. At the right time, when ready, interested, they can refer them to Baby and Me tobacco-free programs where they can get free diapers for staying off cigarettes. Their partners can also be part of the programs and encouraged to be part of that. So we have measured a percent decline in smokers of pregnant and postpartum women. We measure using validated tools depression and anxiety, for example, and again, over the period of time of follow-up, we've shown a decrease in scores from higher to lower being a better outcome. So that's occurred. We've had more women getting emergency food packs for food insecurity, connected to food pantries and things. More importantly, though, of those who screened positive for food insecurity, 60 or more % of those women had gone on to get officially got enrolled in WIC and SNAP for food sustainability, security for their families and themselves. So these are the kinds of things that we've measured for, those are 3 examples.
A big part of why the We Care related projects like CarePlus have worked is because of the people who have given their time to help others. People like Carolina. She's a recovery coach in CarePlus. She recruits mothers into the program, gets to know them and their family, and helps them do life.
My job is just, to be a support, right? But I guess when I'm able to actually see that in someone's life makes a big difference, because you can see, that this person knows that there's someone that's going to help them, that's someone that is going to understand them, and that, they don't have to feel too alone. And also, me providing resources gives them hope and gives them kind of like, not a way out, but they can start looking for those resources themselves now that maybe I've given them a few, and they can start, just building their life, from where they were.
Carolina was hired early because we, even before the grant got started, because we saw that she was such a gem in terms of her empathy and caring and her experience. So she's had a year of work in a methadone clinic in New York, Harlem, and a year of work at the methadone clinic here in Indianapolis, doing individual and group counseling. Again, those are slightly different. Those jobs in methadone clinics are different than what the expectations for an addiction recovery coach is, but it certainly demonstrated her interest, knowledge, and experience with people with addiction, and the ability to be 2 years into this to really be committed. And so she was hired. She went through a special training to become an addiction recovery coach, and is now already being a resource for our current We Care coaches to refer to her, anyone who's interested in having extra care or concern around their addiction. Plus, she's doing her own independent recruitment from treatment centers, from and now currently through the Care Plus program funded by Fairbanks. We'll be recruiting mother babies of babies who were born with neonatal abstinence syndrome out of one of our local NICUs. neonatal intensive care units.
Through the work of people like Carolina, community health workers can have a huge impact on lives. Lots of times, though, success can be bigger than just one person.
Success to me, on a project this large with a problem this big, is any step toward improving positive behaviors and diminishing negative, unhealthy behaviors. And we've done that. We've done that in all 5 of our pillars. The next layer of success is healthy birth weight, because a low birth weight baby is at risk for infant mortality. But even if there's not a mortality outcome with that, a low birth weight baby might be in the NICU for long periods of time, may have developmental delays, may have learning disabilities, etc. So anything we can do to get a baby born over 5.8 ounces is a major outcome for us. So that's the second layer. And then ultimately, with the We Care Plus, our major outcome is decreasing infant mortality, which is a major problem in the state. So those are all successes. Add to care plus then the overlay with women with substance use disorder, often comorbid with mental health concerns, depression, anxiety, and even more serious mental health issues, is getting them connected to behavioral health folks and recovery counseling, whether it be formal with inner outpatient addiction treatment centers, or the major informal networks with Narcotics Anonymous, Alcoholics Anonymous around the city, which is free, or if they're still afraid of that, not ready for those big steps, to just meet with our coaches, who we have a special force of community health workers who get extra training in addiction recovery as addiction and recovery coaches. So they can serve in terms of a supportive role, encouraging, helping them stay clean, helping them get clean, helping them connect, get over their fear of, approaching a treatment center. If they relapse, to not shame or blame them, to be there for them and get them back on track. So we are quantifying, measuring all of that, and that will be our measures of success.
I think definitely if a mom is still struggling with using heroin or any other drug, the fact, that they start thinking about not using anymore, about understanding what they need to do to stop using, like not hanging out with certain people, or, eating healthier, or seeing me more often, or, looking forward to seeing me, because if mom starts making those changes, then, that baby, it will be taken care of. Another big success is if dad is part of the family and dad is supportive of mom, because a lot of times, again, if they don't have any support, they don't feel, that they can do this, right? Yeah. So if there is people in the family that supports moms or dad, then we also know as a health worker or a recovery coach that, there's someone else in that child's life that, it's going to take care, it's going to be part of that baby's life in a positive way.
One of the biggest ways that community health workers succeed is through the trust they build with their clients. That trust is built on empathy, something Carolina says we could all use a little more of when we talk about folks with substance use disorder.
I think a lot of people focus a lot on, they made that choice, that's their fault. But I think, we fail to understand that once they are kind of like too deep in the addiction, that it's not just, a one decision of say, okay, I'm going to stop using, because, at that time, at that point, like your brain has adapted to that, specific drug. So it's not just, that person is going to stop using right away. So, more like the stigma, I think, kind of hopefully, I don't want to say it can go away, because it's not just going to go away, but, I guess more education, and, a lot more support too.
While community health workers can make personal impacts on opioid addiction and family health, they can't fix it all.
Sometimes, as a recovery coach, we can feel useless or powerless. I think that's a better word, powerless, because there isn't a lot of help out there.
For starters, the field is often understaffed, under-equipped, and underused. But when they're used well, community health workers can be a powerful addition to healthy, robust, larger-scale solutions like health systems and hospitals. Come back next time when we zoom out a little bit. We'll talk with Eskenazi Midtown's CEO, Ashley Overly, about how health systems can make an impact in fighting the opioid crisis. Join us then on The Problem. Our theme and additional music cues in this episode were written and performed, as always, by Tessa White and the Natchez Trace. The Problem is produced at Studio 132 in the Regenstrief Institute in Indianapolis, Indiana. We connect and innovate to provide better care and better health. Learn more about our work and how you can get involved at regenstrief.org and see bonus content from this episode, including sources, pictures, and more at regenstrief.org/theproblem.